Good afternoon, everybody. This is my first and initial experience with this technique, and for that technique I used to use it as a primary option and not a secondary option like most of the reported cases of graft transplant for failed macular holes. So I chose this patient, a 24 years old male patient with a history of blunt trauma to the right eye a few months ago with a visual acuity of 160. This is the hole at presentation. You can see how huge it is, and I don't think this otherwise would have closed. This is during the surgery, and of course the technique is well known. In this patient, after removing the epimacular membranes, I chose also to remove completely the ILM all over the macula because you're going to be exposing a large area of the RPE while harvesting the flap with a high incidence of reproliferation. One would say, why didn't you stuff it in? Well, I didn't think that any kind of ILM will close that hole. Some tips I learned that you have to enlarge the graft just not exactly the same size of the hole, because while doing the laser and the diathermy, you're losing a bit of a flap. So I was lucky, and this flap was just a little bit larger than the original hole. I didn't try to insinuate it in, and the only mistake I did, I thought this is a flat retina, so I would use the PFCL later, but when you use a PFCL, it just flies away. So you cannot either work the whole thing under PFCL or just stabilize the flap with some viscoelastic and then put the PFCL. And then I go directly into silicone oil PFCL exchange with trying to remove as much of the PFCL around the graft as well, just not to miss any bubble. This is just 1 week post-operative, the slit lamp photography showing a good integration of the graft, and this is the OCT 1 month post-operative while silicone is still in. You can see actually a foveal contour is forming in spite of like you have seen the graft was a little bit larger than the hole itself. Of course, there is a missing of the ellipsoid zone. There are no photoreceptors under the flap, yet the patient visual acuity improved to 2100. This is the time of the silicone oil removal, and you can see well integration, minimal scarring at the bedside, yet extensive, of course, proliferation at the harvesting site. This one becomes really interesting, and this is 6 months post silicone oil removal, and this is a structural OCT. If you can see at the line, the red arrows here, on the top right, you can see at the time of silicone oil, the RPE and the photoreceptors were just interrupted at the graft. But 6 months post-operatively, there is a line there of probably photoreceptors because it's continuous over what appears to be a scar, and this may explain why the patient had some vision. This is the OCTA of this patient, of course, complete avascular graft whether deep or superficial, extending even beyond the graft to the original tissue. And this is when it really becomes interesting. This is a multifocal ERG. I don't have microperimetry like Dr. Parolini, but this showed some central signals. Of course, less than the normal, and of course should be compared to a preoperative to know for sure, but still this is only detected, the multifocal ERG, by cones. And I have taken the graft from the periphery, so this is really interesting. Are there cone formations somehow? I really don't know. So my initial impressions, it's a promising technique for large macular holes, which are almost impossible to close otherwise. A good graft integration have been seen, and visual acuity improvement has been reported. Maybe more objective ways are needed, and further evaluation of the best place to harvest the graft should be investigated to know where can we get the best photoreceptors, if ever. Thank you very much.
I'm sure Barbara has some comments on this. Thank you, Mama.
Thanks. Well, as I was saying, there are so many open questions on the subject. I think that doing a diathermy or laser is damaging the border. So what I'm doing now, I'm cutting the flap, moving the flap, and then doing diathermy all around just to avoid the damage. And the second thing that I have learned is that if you don't do microperimetry, you don't know where the patient is looking at.
What do you think of multifocal ERGs? Do they give you anything?
I don't know, because I would like to do comparative study, ERG, microperimetry, and vision, and try to see if they match. I'm not sure that they do. I just don't know. I just don't know. But the thing that the patients are reporting an improvement in vision is significant. Probably we are reducing.
And I've shown this line of photoreceptors forming. It was a surprise to me. It was not present immediately post-operatively.
I don't know. We have
Okay, I have a question to you. Of course, beautiful surgery, and I agree what Tamer Mahmoud taught us, but could you explain me why you didn't give a chance to this patient to have ILM flap technique, and you decided to do such a complicated surgery with silicone oil and perfluorocarbon liquid?
Well, the thing
this
is,
case may be solved with just ILM flap and air injection without these difficult methods and without subsequent second surgery, and visual acuity 20/100 will be achieved for sure as well.
okay, this is
maybe better.
Well, I opted to this technique because I think the break was very large. And if I cover it just with the ILM, I think maybe it would heal, like you say, but I'd be stuffing like, glial tissue inside this hole. And we yet don't know if it's really proliferating, inviting healing, inviting glial tissue, fibrous tissue formation, like Dr. Okoye here have shown us. You can see there is no photoreceptor layer, and there is only scar tissue inside the center of the fovea. So the question is, are we closing these holes just mechanically, plugging them in, or are we trying to get some function? So,
well, the thing is that we don't know if
Exactly.
the retina plug itself is just a plug or it's functioning. It's too soon.
If you do this technique, you give at least to the patient a chance to having some improvement. You always can peel ILM and do retina transplant. But please try next time to give a chance to the patient.
okay.
Question from the audience. Just one, sorry.
Abdullah Abdullah from Saudi Arabia. My question: how did you recognize after the flap moved the upper side from the lower side?
Well, that's a very interesting question, and during harvesting the flap, I always take 1 or 2 blood vessels on the surface, so to know which is up and which is down. So I always include a blood vessel in the flap, in the graft.